Thanks, Ben. Thanks, everyone. Pleasure to be up here and talking. So, talking about PAO indications, not just defined by your typical dysplasia with a low lateral center edge angle. These are my disclosures. Typically think about dysplasia with low LCE, elevated tonus angle, and treated with the PAO. I don't think there's a ton of debate about that here. More recently, Dr. Boulet's group has published a more comprehensive classification, looking at your more traditional dysplasia. They classified that as Ottawa L. Then they also took into account the version of the socket, so Ottawa A being anteverted hips and Ottawa P being more retroverted hips. I define this Ottawa A group as a normal lateral center edge angle with a low volume anterior wall. So this is measured by an anterior wall index less than 0.3 and excessive posterior wall coverage. I actually had an opportunity to look at outcomes in this group of patients when I was in fellowship. So these are Ernie Sinks patients, compared a group of Ottawa A hips to a more traditional control group, and noted no difference in outcomes between the two groups. They can do well with a PAO as well. And then on the other side of the same coin, so the retroverted sockets, normal lateral center edge angle, low volume posterior wall, with posterior wall index less than 0.8, and then some of your qualitative signs of retroversion, so posterior wall sign, ischial spine sign, and then crossover greater than 1 centimeter from the roof. This has been looked at with a number of different groups. The Burn group has 10-year outcome data on this, demonstrating significant improvements, improvements in range of motion, and no significant progression of tonus grade or conversion to tonal hip. So to our first case, recently presented this case at an ANA course, and the jury was divided on what the right thing was to do. So I'd be curious to poll the audience on this and what they think would be reasonable. So this is a 22-year-old female. She was a former collegiate swimmer, butterfly stroke, had bilateral anterior hip pain for over 5 years. She'd undergone bilateral hip arthroscopy in 2023, initially noted some mild improvement, now she was worse. Significant pain with activities of daily living, sitting, going for long walks. She had had injections in both hips, both before and after surgery. She noted 2 weeks of complete relief of symptoms in both instances, but these results were not durable. So this is her exam. Mainly had issues with the left hip, so we'll focus on that. Looking at her range of motion, so inflection, she had 5 degrees of internal rotation, relatively normal external rotation. Then prone, she had 50 degrees of internal rotation, and a little bit limited external rotation. Thigh foot angle looks normal. Pain with provocative impingement maneuvers, so straight flexion, internal rotation, and she did not appear to be hypermobile. It's hard to imagine impinging in like a butterfly stroke, but you think about swimmers when they get to the end of the pool, they're all getting in this hyperflex position, their spine's in lordosis, so sort of a maximal position of impingement. So when we think about the ideal hip, or what we think the ideal hip is on the AP pelvis, we're looking at the lateral center edge angle. We think this needs to be between 25 and 35. Acetabular index between 0 and 10. Then we're looking at the anterior and posterior wall coverage. There's normative values for this out of the Burn group with hip to norm software. They've also published on the anterior and posterior wall indices as a surrogate for these. And so we think about the anterior wall, you want it somewhere between 1/3 and halfway across the radius. Then you want your posterior wall pretty close to the center of the femoral head. So these are her x-rays focusing on the left hip here. So we think about reasons for a failed arthroscopy, always concerned about dysplasia, significant bony deformity. Looking at this, if I saw her initially, I probably would have offered her a scope as well, assuming she had a cam lesion. So these are her measurements: lateral center edge angle of 28, tonus angle of 6. Anterior wall index is on the upper limit of normal at 0.47, and then her posterior wall was a little bit deficient at 0.74. Looks like she had an appropriate head neck offset correction with residual alpha angle of 38. And so looking at some of her qualitative measures, so there's the center of her femoral head. She has a cephalad crossover, posterior wall is medial to the center of the femoral head, and then she does have an ischial spine sign, so certainly not a severe retroversion, not as severe as Mike's case that he presented earlier, but what I would call maybe a mild retroversion. These are her MRI, so articular cartilage looks good, the labrum looked good, looks like she maybe had some capsulolabral adhesions in the front, but no obvious reason for failure here. Capsule repair looks good as well. So this is her CT scan. We'll typically do all of our own CT measurements. I find the radiologist's measurements aren't always as accurate as we would like. So you can see her osteochondroplasty looked to be well performed. Coverage looks good in the socket, slightly retroverted. So I measured her at -3 at 1 o'clock and then 10 degrees of aneurysm at 3 o'clock. Her femoral version's 31, giving her a McKibben index of 41. And so it's interesting having such little internal rotation flex, but then she has a lot when she's prone, suggestive maybe of some sort of extra-articular impingement in the subspine region. So I think it's useful in these to create a problem list, trying to help organize your thoughts. So I think for her, she has mild acetabular retroversion, mainly just a low volume posterior wall, type 2 subspine, and then elevated femoral aneurysm. So we talked about different options. First option being just a revision hip arthroscopy, maybe with a little bit of a rim trim and a subspine decompression. Other option being that, adding on a reverse PAO to correct the mild retroversion. If I could poll the audience, who would go for option 1? Option 2, anyone? So talked to her about both. Actually gave her this paper, talked about shared patient decision making. Mike touched on this a little bit earlier, so I won't go super in depth, but the Swiss compared their outcomes of rim trim through a surgical hip dislocation versus an anteverting PAO. Seemed to be pretty similar during the first 5 years, but the results don't seem to be durable. The anteverting PAO seemed to perform better over time than a rim trim. You were about destabilizing the socket, taking some bone away in the front if you already have a deficient posterior wall. So she elected to do all of it. So we scoped her hip, a couple of cartilage scuffs, but overall the cartilage looked okay, no full thickness defects. We did see pretty significant capsulolabral adhesions there in the front. So we began mobilizing those around the front, around the back side. Then once we had done that, we noticed a prominent suture stack, so that was removed, and this was her labrum afterwards. So she had good labral tissue. There was no labral detachment. It looks like the repair seemed to have worked. She just had some adhesions in there that we removed, so I didn't elect to do a re-repair or a labral reconstruction. And this is technically a labral debridement, but we're not actually removing any labral tissue. So then we did her PAO. With her femoral version, I was a little bit worried about overdoing it and making her unstable out the front. So, with K-wires, you estimated we added maybe 10 to 15 degrees of version, and so this is her correction. I find it useful to get x-rays after you've corrected the pelvic tilt to the other side, so it kind of gives you some normative information on what the wall should look like. So you can see she's still retroverted over on the other side, and we got rid of the crossover here on the left. She had a little bit of an offset deformity lateral, so this is straight abduction, so we took a little bit off there through an open arthrotomy. And this is her at 6 months doing well. So on the other end of the spectrum, this is our second case here. It's a 19-year-old female. She's a recreational athlete, college sophomore, presented to us with anterior hip pain for 2 years. Initially began with squats. She had significant pain with prolonged standing, walking, sitting, sleeping. She'd been in physical therapy for 6 months. She had 1 injection with no relief. Of note, she was female, firstborn. She does have a family history of issues with her hips in both her mom and her grandma. So this is her physical examination. Looking at her gait, she walked with a neutral foot progression angle, relatively high range of motion hip, so 45 degrees of internal rotation flexed and 80 degrees of internal rotation prone. Thigh foot angle slightly elevated at 45, so you're thinking about high aneurysm femur here with compensated tibial torsion. She had pain with provocative maneuvers, fader, subspine, instability testing, and then her Beighton score was 5 out of 9. This is her x-ray here, focusing on the right side there. So looking at that socket, you might say maybe it's more in the borderline range. I find these sometimes can be challenging to know where to measure. Do you measure the downslope of the sourceal, or do you take into account that part that starts to slope up a little bit? So this is how I measured things. Got her at 25.1 for LCE, though acknowledge you could probably measure that a little bit less, put her in the borderline category. Tonus angle slightly elevated at 5.9. She does have a low volume anterior wall, so I've got an AWI of 0.22, anterior center edge, low end of normal. No appreciable head neck offset deformity on her x-rays. MRI, cartilage looked good. She did have an anterior superior labral tear. This is your CT scan. So no obvious offset deformity, coronal center edge angle of 28. I find the CT tends to overestimate this a little bit compared to what we get with our standard x-rays. And then she's got a really anteverted socket. So at 1 o'clock, she was 22, and then at 3 o'clock, 31. Femoral version here was 36, giving her a combined given index of 67. So problems for her, at least with regard to the bone, elevated acetabular version as well as femoral version. So we think about options for her. I think the only one I wouldn't consider in isolation is a hip arthroscopy with someone with that much range of motion. I don't think impingement's their problem. I think you could probably consider either a PAO or a femoral osteotomy in isolation with her neutral foot progression angle and the PAO potentially being a little bit easier recovery. We opted for a hip scope and a PAO. So these are arthroscopic photos. She did have anterior labral repair, or anterior labral tear rather. The rest of her cartilage looked good. And placed 2 anchors and associated sutures to repair it. So this is her correction, improved her lateral center edge angle, made the tonus angle more flat, anterior wall index slightly improved as well. And then these are her 3-month postoperative x-rays. LC at 32, tonus angle flat. We improved her anterior wall index up into the more normal range. So I think in summary, the LC is a good screening tool. I think acetabular dysplasia is the 3-dimensional problem. We're starting to appreciate versional abnormalities a little bit more. And I think the acetabular and femoral version play an important role in the arthrokinematics of the joint.
When you're doing osteotomies, correcting acetabular anteversion, retroversion, are you doing something different with your cuts?
Not doing anything different with the cuts. I think for the anteverted sockets, it's really hard to retrovert without over-covering and downsloping the tonus angle. So I find it challenging to do that. So I feel like it's a subtle correction and you're trying to move it a lot and you're a lot of times end up back where you started it in the first place. But I've not changed the cuts significantly for based on the way you're moving it.
Is anybody doing anything for PAOs different, doing any different cuts for anteverting, retroverting PAOs? Yes, one more question. Yeah.